Hi, everyone. We're going to get started with our first panel. If you want to take your seats. All right, everyone, we're going to get started. I'm so glad that there's so much conversation going, but we're going to try to keep us on track here. You all are going to make me clap like it's my students. Yeah, like clap once if you can hear me. There we go. All right, thank you. I'm so glad everyone's so enthusiastic. That was a really great keynote. So as everyone takes their seats, we'll just get started here. Thank you so much for joining us this morning and for our first panel in what is going to prove to be, I think, a really fantastic day of learning. This is the Connecting to Community Meeting Health-Related Social Needs During Reentry panel. My name is Erika Hanson. I'm a clinical instructor here at the Center for Health Law and Policy Innovation of Harvard Law School, or CHLPI, where my work really focuses on the legal pathways and policy implementation strategies to address the social determinants of health and health equity. And as we heard this morning from Vicki, and really an outstanding keynote, we know that incarceration has serious impacts on an individual's health outcomes really after release. We saw studies have shown strong associations between incarceration and increases in premature death from infectious diseases, chronic disease, drug use, and suicide. Incarceration also has unique health impacts for women, in particular, pregnant people and their infants. However, we also know that the social determinants of health, such as access to food, and we heard housing, employment, drive as much as 50% of health outcomes. And we know that access to services that address these health-related social needs have the potential to reduce emergency department visits, inpatient hospital admissions, and overdose upon reentry, improving health outcomes overall. Moreover, addressing people's underlying health-related social needs enhances really all of our abilities to succeed and thrive in our communities. Therefore, in the guidance that the Centers for Medicare and Medicaid Services encouraging states to apply for these 1115 Medicaid demonstrations that we heard from Vicki to increase healthcare access and address poor health outcomes for people leaving carceral facilities, it actually requires projects to include case management and the connections of these individuals with health-related social needs services during the pre-release period and upon re-entry. So today we're fortunate to have with us a really diverse panel to discuss the health-related social needs of people who have been involved in the criminal legal system and what will be required to successfully meet their needs during re-entry from a carceral facility. And we're going to talk about how to capitalize on lessons they've learned and their experiences on the ground in programs seeking to address increased access to health-related social needs services, really in order to maximize the potential of programs like these 1115 waivers and really the other policy advancements that Vicki talked about, in order to not just smooth re-entry, but to really break recidivism. So today we are really lucky to have with us, starting from the edge here, Sheriff Peter J. Koutoujian. As a prosecutor, legislator, professor, and law enforcement leader, Sheriff Koutoujian has worked on the intricate issues that intersect public safety and public health throughout his career. Sheriff Koutoujian is a graduate of Bridgewater State University, the New England School of Law, and Harvard University's Kennedy School of Government. While a state representative, Peter Koutoujian oversaw Massachusetts healthcare priorities Priorities as chairman of the Committee on Public Health. He led the state's first commissions on prescription drug abuse, as well as ethnic disparities in healthcare. As sheriff, his use of specialty units to target treatment towards unique populations, such as young adults and military veterans, has earned national acclaim. More importantly, his commitment to data-driven research has made these programs and their results reduced recidivism and healthier, safer communities replicable across the country. Sheriff Koutoujian has been elected by his statewide and national peers to serve as both the president of Major County Sheriffs of America and the Massachusetts Sheriffs Association. Next to him, we have Allison Sequeira, who is the Teaching Kitchen Program Manager at Community Servings here in Massachusetts. With a background in social work, experiential education, and culinary, as well as personal experience with loved ones coming home from incarceration, Allison brings a deep passion to her work as the Senior Program Manager of the Teaching Kitchen Culinary Job Training at Community Servings. The program provides training and support for individuals facing barriers to employment with the goal of accessing permanent employment in the food industry. Prior to her work at Community Servings, Allison spent 6 years working at Health Leads Boston, training advocates to address the social determinants of health of patients and their families at Boston Medical Center and the Dimmick Community Health Center. Next to her, we have Maggie Beiser, Director of HCV Services at Boston Healthcare for the Homeless program. Maggie has been an adult nurse practitioner at Boston Healthcare for the Homeless program since 2008. She provides primary care, addiction treatment, and HIV specialty care to adults living with or at risk for HIV. In 2014, she developed and implemented primary care-based hepatitis C treatment program, which has treated over 1,300 individuals, including justice-involved individuals, via a correctional linkage to care grant from the Massachusetts Department of Health. She participates in HCV-related education, research, advocacy, and policy planning at local, state, and national levels. And finally, last but not least, is Leslie Credle, Executive Director of Justice for Housing. Leslie is leading the crusade to dismantle discriminatory housing policies that are targeting justice-involved individuals, which lead to homelessness, recidivism, and the separation of families. In 2002, Leslie was invited to the White House as a housing policy expert for a roundtable discussion about the actions the Biden administration could take to advance tenant protections and rental affordability. That year, she was chosen also as the recipient of the Echo Green Fellow. So thank you. Welcome all of our wonderful panelists for this great discussion. I'm just so excited for all the diversity of voices we have here. So to start, I want each of our panelists to kind of give us some context for the work that they've done in this space. So we'll start with Leslie with this question. Can you tell us about your work in this space to address the health-related social needs for individuals who are experiencing or have experienced reentry, and really why that work is so important?
Sure. First, thank Harvard, and thank you, Erika, for inviting me here. One thing that wasn't mentioned is that I'm also formerly incarcerated. So I also experienced reentry and the barriers of healthcare. One thing that we have to realize is that when you're incarcerated, the lack of health care, delayed health care, or inadequate health care contributes to illnesses that are, I could say that when you are released, they become life-threatening, apparent, intentionally ignored. You're waiting for health care when you're incarcerated for sometimes 5 to 10 years. If you're in a prison, you cannot receive health care unless you have more than 5 years on your sentence. So a lot of people don't know that. The food is also a contributor to bad health. when during COVID lockdown, some of the labels said not for human consumption. The food was meant for making dog food. Also, expired food is a lot of times we see expired food or yellow water. All of these contribute to illnesses that go unmet. And when you are released, the first thing you do is go to your primary care. I lost 2 friends of cancer 1 year after they were released. They were diagnosed as soon as they were reentered. They were diagnosed with terminal cancer. So things like that go unmet or ignored. So first we have to change that culture inside the prison. Our impact at Justice for Housing has been changing the narrative, actually bringing the attention to these issues, also providing wraparound services that address case management, unmet trauma. There's a lot of trauma while you're incarcerated that goes unmet. And once released, a lot of people aren't aware of all of the impact it has had on them mentally, including myself. I have anxiety, which I never had before. So our work basically connects organizations who provide wraparound services like Whittier Street and trauma-informed care from Change Comes Now to address these issues. Substance abuse. My sister Stacy Borden deals with women who have social abuse issues, and she has a reentry home as well addressing these issues. So these are some of the ways that we have changed the narrative, creating homes for people. You cannot heal until you have a home. You cannot get a job until you have a home. You cannot address any social determinant of health until you have a home. Reuniting your families, just the impact of being separated or the mental stress of being homeless, all of that contributes to depression, taxpayer dollars. So these are some of the ways that we have been successful, is by housing 101 individuals in our SHARP program, and we have a 0% recidivism rate from doing so.
Thank you, Leslie, and thank you for sharing your personal experience as well as those really wonderful accomplishments. Maggie, can you share a little bit about, what your program does in your experience in connecting folks to health-related social needs services?
Sure. So at Boston Healthcare for the Homeless program, we have 2 sort of specific programs that are working sort of in the Suffolk County Houses of Correction, and they're grant funded right now. So one is a SAMHSA funded program, and it is orchestrated by a wonderful team that's here today called the RISE team, which is Reentry Initiatives for Support and Empowerment. And they are grant funded to really identify in the 3 months prior to release people with opioid use disorder, make sure that they're on medications for OUD treatment, and really with a high intensity of behavioral health and case management support, offer pre-release, day of release services that are often meeting people at the jail and providing them with material resources, same-day appointments, same-day prescriptions, navigation through the healthcare system, as well as phones in some cases, and then working with them in the 6 months after as well, and to make sure that they transition to the sort of comprehensive community health center services smoothly. And then we have a correctional linkage to care program, which is really specifically around linking people with hepatitis C to treatment after release. And frankly, that's a rapidly evolving space. We're lucky to be seeing more Hep C treatment in the jail system. As you saw from Vicki's wonderful presentation, the prevalence of Hep C in jails and prisons is inordinately higher than the rest of the in the non-incarcerated population. And the morbidity and mortality related to that is also about a significant order higher. And so we're glad to be seeing more treatment happening, but there's still a lot of need, and the close and rapid linkage to those services at time of release is something that the Department of Public Health has invested in. And so we have, at Healthcare for the Homeless, really overlaid sort of the opportunity of those two funding streams into this our RISE team to try to make those services as accessible and functional as possible. And I will say we are well aware they are not as expansive and comprehensive as we wish that they could be, and that's something I think we hope the waiver might give us an opportunity to do.
Thanks, Maggie. That'll definitely give us a setup for our conversation later. I think that gives us a nice transition to you, Sheriff, talking about how Maggie's program's trying to reach in and kind of coordinate a little bit to talk about what you are doing in Middlesex County and kind of maybe what the traditional trajectory is for someone coming into a carceral setting and then trying to be released, and what you're doing to pilot some kind of interesting programs there. It should be on, I think.
I can start. You want to work on that for a second, Sarah? I can begin anyway. Peter Koutoujian, Sheriff in Middlesex County, right here in Massachusetts. Any of you guys Harvard students at all in here? Raise your hands. All right. So when you graduate, I don't know if you've been to a commencement, but the Middlesex Sheriff, and joined by the Suffolk Sheriff Steve Tompkins, actually gets to formally open and close the commencement. When you see that weird-looking figure in a top hat, coattails of staff, and a booming voice, that's me. So it's actually, that's the highlight of my experience as sheriff. It's all downhill from there, really, too. I am actually kidding about that because I love being sheriff. I love my job. I love what I get to do. You're really lucky to have so many great presenters here this morning. Vicki Washino from HARP, if not the foremost voice in the nation, one of the foremost voices in the nation on Medicaid and Medicare exclusion policy when these voices were needed. To have Leslie with lived experience, I commend these organizations for having Leslie with lived experience. We don't get enough lived experience on these panels and these discussions, and it's an important voice that we need to have. And to have my fellow panelists, it's really great to be here. These convenings are really important to discuss these matters, not just so that we can all learn from each other, although that's really important, but we can spread the word. And part of that is the participation of carceral, people that run carceral facilities. I've got Sheriff Pat McDermott from Norfolk County that's here. I know Steve Tompkins is somewhere around. I know his staff is here as well. These issues are very important to us, and we are very committed to helping solve them. I want to say one thing as I start is, we speak about the health-related social needs. Leslie mentioned it, the ones that affect our health. And when you consider what they are, mental health, substance use, trauma, education access or lack thereof, homelessness, poverty, social network, and their healthcare network issues, those are those health-related, issues that impact one's health. Those are, when you think about what is justice, when you consider what are justice-related needs, they're exactly the same. The issues that drive people into being justice involved in incarceration, mental health, substance use, trauma, lack of education access, homelessness, poverty, social network, and lack of healthcare access. The very same things that which lead us to ill health lead us to justice involvement as well. And if we can solve a lot of these issues, then we can actually not just make people healthier and happier, but also keep them away from the justice system. I live at the intersection of public health and public safety. And I'll just tell you, I was just thinking about this recently because this sheriff, when you consider what's going on in the law enforcement world and sheriffs really too, this week, just in 1 week, I was just speaking at the with the director of the Office of National Drug Control Policy in SAMHSA at the Johns Hopkins Bloomberg Center for Mental Health, their addiction policy last week, the convention they had. I was in DC talking about expanding methadone access. Today speaking about Medicaid and my EP in Atlanta. I'm leaving tomorrow to speak about opioid addiction at the RX Summit, right? This is our world. It's that intersection of public health and public safety. I want to tell you a few numbers. Now, this is April Fool's Day. By the way, it's my daughter's 15th birthday, so that's, yeah. Well, she's 15, so it's not, she's not always as sweet as I wish she was. I hope she gets sweet again. She's a doll. But, so it's April Fool's Day, but I'm gonna tell you a few numbers, and these numbers are no April Fool's joke. All right, these are very serious numbers. For people that enter our facility, almost 47% have an already diagnosed substance use disorder. By the way, these numbers make perfect sense, of course, right? But they're always important to have the data out there. 47% have an already diagnosed substance use disorder, diagnosed, right? 57% have an already diagnosed mental illness. 57% of people that come in already have a diagnosed mental health issue, right? 71% have a chronic illness, and that ranges from general health chronicity to psychiatric chronic illnesses as designated by the National Commission on Correctional Health Care. 71.7%, 72%. 75% of our population have an open mental health case with our clinicians currently. And by the way, this can be sleep disorder and anxiety and things like that. It's an anxious kind of place for a lot of people, as you should, if you're not anxious in jail, then, there's something maybe that we should be worried about a little bit more too, right? Let's see, 92% of those with a substance use disorder already also have a diagnosed mental illness. I'll give you two other quick ones. 76% of those with chronic illnesses are psychiatric disorders as defined by NCCHC as well. 74% co-occurrence with a diagnosed mental illness that also have a chronic illness, and 64% co-occurrence with a diagnosed substance use disorder that also have a chronic illness. These are the same populations. They're a really sick population. And our populations are becoming more and more acute, right, and needing more care. And this is very troubling. So we've done a lot of work with these organizations, and I will say, basically, in closing this comments, I'm really proud of the programs we have at the Middlesex Sheriff's Office, the Jail and House of Corrections. I really don't think that, aside from my Suffolk and Norfolk County counterparts here, except for those two, I don't think you're gonna find any better programming or educational opportunities or healthcare or mental health care in the country. And I've been around this country, I kind of know what's out there, really proud of them. But you shouldn't have to come to jail to get good treatment, right? You should be able to get these types of treatments and resources in the community so you never have to become justice involved, and even further down the road become incarcerated as well. So I think we just have an obligation to treat these issues before you come to be justice involved. And I believe that this forum is an incredible way to start to speak to them. We always have to be thinking about before they become justice involved, but if they are just involved, what the heck are we gonna do for these people so they don't have to be justice involved again? Thank you.
Thank you, Sheriff, and thank you for being here on your daughter's 15th birthday. We really appreciate it. Allison, can you talk to what Community Servings does? I think we are gonna finish this question with you because I really like the story and the program that you have there and how it kind of nicely closes up focusing on health-related social needs in the community.
Hey, thanks, Erika. So I work at Community Servings. This is actually a food and nutrition agency. We have a massive kitchen that makes over 5,000 meals from scratch every day for people living with serious illnesses. So my role there is I manage a job training program. I think we're pretty small but mighty. We graduate about 60 students per year through 8 cohorts. And a large percentage of the people we are serving in our program, providing training to, are coming home from incarceration. We provide 12 weeks of training. These individuals work in our kitchens. They're with us for 28 hours per week, Monday through Thursday. They earn their ServSafe certification, which is a nationally recognized food safety certificate. We work together with each person to write a resume, to practice interview skills, to get people back out into the community. I think actually the most important thing that we do together is not related to cooking techniques or ServSafe certification or resume writing, but actually giving individuals a sense of belonging, a sense of purpose, and a routine to come to every day. I'll share one quick story about how we got to where we are as a program right now. Just before COVID, we had an individual named Robert. He had come out of incarceration. Somehow he'd heard about our program. He thought, I could work in a kitchen. That's a job I could do. He actually walked to community surveys the day he was released. He showed up to us. It was very lucky timing for all of us because we had a class about to start 3 days later. He did an application. I interviewed him. I said, let's do it. And there he was. He came right back and he got through the class. And 3 weeks into the class, I realized that Robert was actually coming every day when community surveys opened at 6 a.m. and working in our kitchen quietly. I didn't know this for like 3 weeks. He was just doing it quietly, helping out where he could. We were down a dishwasher at the time. He was actually staying till 8 p.m. continuing to help in our dish room. He was an amazing, amazing worker who was so committed to helping his community. He cared really deeply about the mission of the agency and he really wanted to give back. He was actually the first person. We had this very small grant from the Roxbury Court, enough funding for us to pay 2 people an hourly wage while they trained with us. And it was just a very small pilot to say, what impact would it have if we could pay an hourly wage to individuals while they did training? Would this help people access training? We had so many people who wanted to attend training. They wanted to get further into a career. They wanted to earn a professional reference, but literally couldn't afford to attend a free job training program. And we also had people who were starting training but couldn't finish the 12 weeks. So Robert was the very first person who we were able to use this grant funding to pay an hourly wage. I'm really proud to say that now where we stand is we have funding that everybody earns an hourly wage, and a big focus of that effort for me was realizing that the many folks we were serving and training who were coming home from incarceration, this was a huge piece of access for people. We constantly heard, what I really need is a job, but I guess if I need training to get a job, I'll just get by until that point. So I think this is an important piece of our training currently, is saying, we do outreach within the Suffolk County House of Corrections. We meet people at times before they come out. We're getting applicants from individuals that they're writing on the top of the application. This is my release date. So we're really trying to catch people that need that routine and that immediate access to employment and earning.
Thank you, Allison, and thank you all for sharing. I think you are hearing from people who are actually implementing programs now to help break that cycle of recidivism. But we hit on something also that Vicky mentioned. I don't know if you heard, but all of these programs are grant funded right now, right? And so we're hearing like kind of small scale grant funding. So I'm hoping that each of you can talk about with your programs, what is the potential of a policy like this 1115 waiver to address health-related social needs and kind of help accelerate the programs and the wonderful work that you're doing. We'll go in the same order that we just went in. So Leslie, I'm hoping that you can answer that question and talk about what an impact of this policy could be for the work that Justice for Housing is doing.
Enormous. These policies will help us do the work that has been stalled or not a lot of resources to do. For example, we've become change makers at Justice for Housing. We have historic programs no one was addressing. Housing is the key to a successful reentry and preventing recidivism, right? So we don't just house people though. We are also addressing the policies, the punitive policies that create barriers for people. We created 12 policy recommendations that we use to dismantle punitive housing authority policies, right? Across the nation, housing authorities was one of the ways that people coming out of prison can't afford regular housing, so a lot of them try to go back to their homes when they're incarcerated. But housing authorities were creating barriers. People couldn't come out of prison and go back to their home if they lived in subsidized housing. And this affected Black communities. Majority of people in prison were minorities, so this affected our Black communities. It separated families, and it caused a lot of harm. And so what we have done is worked with housing authorities to get them to change their admin plans. Boston Housing was the first housing authority to be innovative and open their mind to accept that the punitive housing policies that they had in place were actually causing more harm, and it's more impactful for them to house formerly incarcerated people for taxpayer dollars, save health, health care. Also, it is a prevention, right? It's a prevention of public safety, public health care, and these policies have addressed those issues. Now we have people coming out of prison. We had 2 lifers coming right home into their homes. Husbands weren't allowed to live with wives. Children weren't allowed to live with their parents. And so just imagine coming out of prison and you're told that you can't go to your home, and that forces people homeless. So that was driving up the homeless rate, and it caused a lot of recidivism. And so what we have done at Justice for Housing is dismantle that punitive system by asking housing authorities to adopt our 12 policy recommendations, which dismantle those policies that came from the 1994 crime bill. And we have housed 300 people overall through all of our programs in 3 years. And it has paved the pathway for others to follow, and addressing the lowering the recidivism rate in Massachusetts. It's the first year, 2019 was the first year it started decreasing. It was at 35% for decades. Now it's at 29%. And I really believe it's from the work that grassroots organizers who are directly affected in the community, like Justice for Housing and New Beginnings and Transformative Prison Project, and a lot of other organizations who do this work. Now connecting us with the DLC and connecting us with is what's missing. And so that continuum of care needs to be, we need to collaborate and start listening to each other and start respecting each other, and so that we can have a healthy community.
For sure, and hopefully this is a good step in that direction. So thank you for being here, Leslie, and contributing to that. Maggie, what is the potential of a policy like the 1115 waiver to further programs like yours?
I think it's incredible. I mean, I'm very pie in the sky about this. I think, having so much work be grant funded means that we're very siloed. We're very disease specific, we're very condition specific, and it's not it's working as best as it can, and it's not good enough. I think, Medicaid is the lever. I think community health centers are the logical place to try to expand these and bring community health center services that are inherently meant to be wraparound and integrated, behavioral health oriented and case management focused. I think bringing that type of model into the pre-release period, starting those relationships, prescriptions, care, relationships, all of those things have an incredible potential, and that they need to be, comprehensive across all disease states, all conditions. When we focus in on just one thing, we are missing a huge population and lots of people who are going to go on and develop chronic diseases and conditions that are just not recognized yet. So I think it's, broadening and trying to find the the greatest systems that are going to be able to comprehensively address these issues for the most people are what I think what this waiver gives us the opportunity to do. And I will just get very narrow for 1 second to say that hepatitis C, it can be eliminated. There is an elimination plan at the World Health Organization level, the country, the state. We're all working on these plans, and every single one says you cannot get there unless you address hep C treatment for incarcerated populations. These are 8 to 12-week treatments, and a 90-day window gives us an incredible opportunity to treat a lot of people before people are released. So, yeah.
That's great. And I think an important point too is that you as the community health center can bill for it, right? And get reimbursed for the work that you're doing under Medicaid.
And if you don't mind, I would mention, so the work we're doing now, we're doing telehealth visits, we're doing behavioral health visits that are not reimbursable right now. And we have the structure, we have the motivation, we have the relationships within the houses of correction, but if we could bill for them, how much more could that grow? How many more health centers could get involved in this? And frankly, health centers are struggling. They're struggling. We have to be able to build to survive and to be able to expand. So, yeah.
That's great. Sheriff, you made a great point about the relationship between health-related social needs and the criminal legal system. Can you talk about the potential of policies like this waiver to kind of transform what you're seeing from the carceral side?
So I will say this, and Vicki has seen we've spoken nationally. I know we've got Autumn Boylan coming in from California today. I don't know if Autumn's here yet, but I say it all across this country. This is a once-in-a-generation opportunity to provide health care for those in need that really should have had it. Most of these people are, that we're speaking about are pretrial. They've not been convicted of a crime, but their Medicaid has been terminated simply because of their status. And the states have been responsible for picking it up, which is not really the big issue here. It's the opportunity to provide care. I always say a jail is not a fortress on a hill, it's part of a community, and if you don't have the connections and the knowledge, education, and understanding of the community and those relationships in the community, then our mission will fail. And so will the community's mission, quite honestly, too, right? So when you consider that MIEP was 1965, it's been in place since 1965, and back then we had about 210,000 people being released from prisons each year. We didn't even keep numbers for jails. And then today, it's about 600 some odd thousand people being released from prisons each year. So that population has tripled. And our jails are releasing 10 to 11 million people per year. We're speaking about the jails, which is more that pretrial population, and the shorter term sentences for the houses of corrections and otherwise. You're speaking about treating people much more closely to their lives, to their communities, to their streets. And it's a churning population in greater need at the time they come to us. I mean, honestly, if you're running a prison, the people come to jail first. We deal with we stabilize their mental health, their substance use issues, we medically manage withdrawal, whatever we need to do, put them on an MAT, and then at some point later they go to the prison. They've already been stabilized by us. But for us, they might just get back out in a week or in a couple of months or in a couple of years. And that important relationship is crucial to have. This policy, when I first thought about it, I always thought it was going to save healthcare dollars for the states. And I think that is true to a degree, except that I think the state's gonna take the money from me anyway. They're not gonna let me keep it, right? That's what they do. Federal money's come in, they'll keep it. And that's okay, I get it. They fund us, so they get to keep it, I suppose, right? But I'm not gonna see that money. But for many of us across the nation, not here in Massachusetts, I'm gonna be clear, it will also help raise the level of health care in organizations, but most importantly, to provide for that continuity of care from inside to outside. From outside to inside to outside, really, too, right? That's the way you have to think about it, outside to inside to outside. It'll improve health outcomes, it'll enhance public safety, it'll knock down traditional barriers to accessing healthcare, especially for vulnerable communities. I mean, and I'm talking about race, ethnicity, immigration status, mental health. I think of that as in those that are, that suffer addiction, right? These are vulnerable communities, so it'll help improve their health outcomes on the margins, right? And it'll save taxpayer dollars, but most importantly, to provide that continuity of care. We have a navigator program in Middlesex Jail, in House of Corrections, and that we do a lot of work with the in-reach and the outreach, right? And it has proved to be very successful. By the way, one of the other things we have to think about, this isn't just about reducing recidivism, this is about people making people happier and healthy members of their community, but also keeping people alive, right? That's kind of one of the main things we forget. We're just trying to keep people alive as they re-enter communities too. And so our navigator works really well, but this will allow for community members, community organizations to have embedded navigators inside with us. So we'll have a navigator that's in with us, passing to the outside, but our partners will have navigators embedded with us that will then kind of bring them right back out to the provider that will provide that care. That's a crucial way to handle these folks. And I think that, we've got to get this right. I've always said that you've got to get corrections to the table and you've got to get lived experience at the table, because well-meaning policy health people, and I'm a well-meaning policy health person too, right? I was the chairman of healthcare when I was in the legislature. I'm a policy wonk. I love that stuff. But you could forget that you've got to get people from different disparate perspectives on that table, or it's not going to work. And already California is struggling a little bit because that they didn't get corrections at the table early enough, right? And now they're trying to fix it all up. They didn't get lived experience. I don't know about lived experience, but I'm assuming they didn't get lived experience early enough to the table. Here in Massachusetts, we kind of knew this was coming. We were fighting for it, by the way. We supported this completely, and we forced our way to the table just to make sure that they weren't asking us to do things that didn't make sense, would be wasteful, or we couldn't use it to the utmost, to the best way we can use it. So when I say once in a lifetime, once in a generation opportunity, I really mean that. If we miss this opportunity, we don't get it fully right, then we'll have lost a lot of lives and lost a lot of families in our communities that we could have saved.
I appreciate that, and I love the idea of making connections, and that's what we're doing here today, and I love this table up here. Allison, can you talk about the potential for the 1115 waiver for a program like yours, speaking of making connections?
So I think specifically thinking about employment, there's a few things that I think this waiver could accomplish. One is that a lot of the folks who we see in our program that are coming home from incarceration and or are living with a substance use disorder, we are seeing a lot of people with an enormous backlog of appointments. People that they're doing all the things that they need to do, they should be doing. These are all very good things. But if we were an actual employer and not a job training program, I don't know that these individuals would be able to sustain employment because they have so many appointments all scattered throughout the week. And as a job training program, we say, yes, of course, like you need to go to all of those appointments, but there's this significant backlog. So when I think about that 90-day window and that opportunity, especially that Maggie's speaking of being able to provide care, mental health care, physical health care, dental care, like all of these basic needs, as much of that as humanly possible could be provided prior to release, I think would make such an impact on people's ability to then navigate what they're trying to achieve next in their lives. So that's one really specific thing that I see as an opportunity. I also think a huge barrier that we see is people lacking IDs. Again, like super basic, but when you are trying to get an appointment at the RMV and the wait is months off, and maybe the next closest appointment is way out in the suburbs and you can't access it because you rely on public transportation, like that is not reasonable. And so to keep people without IDs for months on end just because the system is not working well, it just seems like such an opportunity for these waivers to say, like, can we get more services in those 90 days pre-release? Let's make sure people go out with the IDs that they're going to need so that they can access employment, so that they can apply for public benefits. That's a huge need. And then the third thing, I think, just very basic, is giving people access to a T-Pass, at least in this area. Like helping people with reasonable access to transportation is another real challenge that we see. I have a lot of students that before they get that first check, they're literally walking to class every day. They're staying in all sorts of different places. Many of them don't have a consistent place to sleep at night. And so they're walking, and that is really taxing for people, and it's at times means they're walking through neighborhoods that they don't want to be in. That's something I talk a lot with my students about, how do they keep themselves safe, and what neighborhoods are they trying to avoid as we think about employment, but even just people getting to class each day, getting to the appointments that they need to get to, so helping people with transportation. And then, in my dream world, I also would love to see many, many more subsidized employment opportunities. We are just one very small program. There are other programs in the Boston area, but I think there's not nearly enough. And I really deeply believe that giving people access to employment as soon as possible after release so that they have a place to go, a routine, a schedule, a means of supporting themselves and finding a new place in the world is just a very basic need that there's so much more that needs to be done to help people.
Thank you, Allison. That's really great. And I'll add my 2 cents here is that a lot of states, while they're experimenting with these reentry waivers, are also experimenting with health-related social need waivers where they'll connect people through Medicaid to things like housing supports, food supports, transportation, like Allison is saying. And I think that there's a opportunity to connect these 2 things. So like we'll hear maybe from California later, but something that they're doing is that the reentry population is actually prioritized for access to the health-related social needs through the health-related social needs waiver. In Massachusetts, for instance, we have what's called the Flexible Services Program, which is our health-related social needs waiver. Maybe there's some opportunity to prioritize the reentry population once we get the reentry waiver in Massachusetts and in similar states, right? So that you can get access to things like food, housing, and transportation, right? And get legal services even, right? So as a legal services attorney, I've dealt with that a ton of times, right? Having my reentry clients not having an ID, we couldn't get them medication, we couldn't get them on benefits. That always had to be the first thing that I had to do as a legal services attorney. So we're gonna turn it over now to audience questions. We'll have some roving mics. I know that I have some questions, but does anyone in the audience have a question for the panelists? We have one back here. John?
Yes, Leslie, I have a question for you. You're doing awesome work with housing, which some of us who do reentry work know is the most important thing to do, as you said yourself. I just wonder, was there a key leader in HUD or anywhere else that really helped you along? And I ask that partly because I know in Baltimore, the sheriff mentioned Johns Hopkins. Nothing was happening at Johns Hopkins with jobs until the CEO of Johns Hopkins, Ron Peterson, he got an award from Obama for this, but he just told his HR staff to hire people coming out who were prepared for jobs with a wonderful reentry program called Turnaround Tuesday. Ron Peterson's retired, he's now the chairman of the board of the Turnaround Tuesday reentry organization, but he made it happen. His staff was not doing what he told them to do until he made it happen. I'm just wondering, was there a key leader in housing that helped you?
Yes. Currently, we are in contact with Deputy Director Demetria McCain. She is the Deputy Director of the Office of Fair Housing and Equity at HUD. And they deal with housing discrimination, housing barriers. And one of what caught their attention was our policies, which mirrored Marcia Fudge, President Biden's housing secretary. Our housing policies were created, and when she put her memo out, they mirrored our Far From Home report, which is our Bible, which is how we change the narrative and get to the root causes of incarceration and dismantle that systemic racism that comes with punitive housing policies.
I'm glad to hear that you're helping to influence them.
Hi, I'm Kristen. I'm with Colorado Medicaid and Very exciting. We just hours ago submitted our 1115 waiver for CMS. Very exciting. So one of my questions is kind of, again, I'm from Medicaid, so I have to ask about money. What are some of the traditional state or federal resources that can really help support the implementation of this? For example, in Colorado, we are in a lawsuit, and so we have a number of fines that we put towards individuals who are facing competency restoration issues, right? We have the AGs, you know, the attorney generals and all those money that goes to states. Where do you see the intersection of kind of this, there's this very specific federal money that comes with all the rules. Where are the other places that we're gonna get the funding to help support some of the things that you all were talking about, the job reentry programs, the support connection programs that can't be paid for with this?
Everyone's looking at me, so I guess I'll have to answer that. I mean, one thing, Kristen, congratulations on your waiver. I think there's 3 states right now that have a completed waiver. It's California, Washington State, is it Montana? Yeah, so, which I always find to be this really cool anomaly, right, to have it in Montana. By the way, I think there's 10 states that are not expansion states, is that correct, something like that, Vicki? That are not Medicaid expansion states, that are still fighting actively the expansion? I just don't understand that, right? I don't understand how a legislature can say we're not going to accept federal dollars to help poor people with their health care, right? It's mind-boggling to me. So congratulations on your process. I mean, I think some of the things that need to be laid in place, one of the things that we did was when I first became sheriff, and we started, because I was aware of it because of my healthcare, legislative background, we did a suspension versus termination. So this is one of the things that everyone should be kind of clear about, the idea of, people would come in, they'd be terminated from their Medicare coverage, their Medicaid, and then they'd be released and they'd have to go back sign up for it, which is, I have a hard, my wife has to do that stuff for me. I don't have the attention span to go through all those pages of application, right? And for people that don't have those support systems, I mean, it's really crushing. So they're not doing it. So we actually fought for the suspension versus termination. I don't know if you guys do that yet, but it's really crucial. Now, our system isn't up and running technologically as it should be, but theoretically it's in place, right? Unfortunately. So I just think that a lot of these monies coming in will bring in new monies. I mean, we're doing we've got Chelsea from the Middlesex Restoration Center, and as you bring in monies for these things, more of these granting organizations will see the value and the investment, and then they will say, I want to invest in that. And I think you just have to make a good case. I always say, when I was chairman of healthcare, I used to have all these public health, and Bob, who just asked a question, would remember these days. They'd come in and say, we need more money for this and for that, and you make perfect sense, but they never had any data, right? And they never had data, so you could never really go to your leadership and say, this is what's happening in the community. And so I think having that data is crucially important. I always say, data without good data, vision without good data is just a hallucination, right? So you need your data in order to make your cases. And the more we can collect our data, the more we can make those cases, not just to the governmental entities in our own government that's going to be pushing out the monies, but also to those nonprofits and others that will that are philanthropic in nature. So I just think that's really important. Have that. Show your proof of concept. Show that it's working. Prove efficacy to some degree as much as you can, or at least the professionalism of what you're doing, best practices, and then I think some of those monies will flow as well.
I would also add just that I'm looking at our benefits manager across the room here, and just to say that there is I think a well-established communication infrastructure across the mass health entities and the ACOs within, and that is, we've I think been pretty fortunate. It's a relatively dynamic and transparent relationship, and I think that's a very state-to-state experience, but I think we will have to be very closely in touch with them, as well as our Medicaid pharmacy drug utilization program, which again, we're very fortunate to have open communication with. But in terms of how this will actually look, I think we'll have to push for what we want and figure out how we will pay for it. We actually have a medical respite program at Boston Healthcare for the Homeless program, and it didn't fit into any logical categories. It's not a nursing home, it's not an outpatient center, and we were able to work with our state government and our mass health group, this is a long time ago, but to carve out a way to make it functional. So I think it's possible.
One other thing I'd add in too, is check with your Medicaid providers, not just the community providers. You gotta build them up, right? So this thing is, sometimes you see a best practice established and another facility will replicate it, but they didn't, I remember we did a veterans program and another county in Arizona replicated it, but they didn't build the relationship with the community providers, and so basically it didn't work as well as it should have, right? So they didn't have those relationships. So I think as well as having lived experience and corrections at the table, the Medicaid providers themselves, I was at a conference speaking in Chicago. What was the name of that group? The Medicaid providers. Do you know, Vicki, what that would have been? It was all the Medicaid providers. They were an industry association. And I asked a question at the plenary session. They had 6 of the most brilliant Medicaid, insurance minds. These are very smart people, and they're speaking, and really good people, of course. But I actually raised my hand. Sometimes I like to be the skunk at a garden party because no one's addressing MIEP, and this is my baby, right? So I was kind of getting mad. This is the opportunity that I see that we should be talking about. So I asked them, I said, have you guys thought, because I think it's not only is it a responsibility, but it could also be, if done right, a good business practice. And if you don't make it a good business practice, then it won't be a good business practice, so you gotta find out a way. I said, I know that you guys care about this, I know you care about these communities. How are you thinking about this? And actually, the look that we all gave each other at that last question, was what I got out of 6 of the brightest minds in the country, where they looked at each other and didn't have an answer as to, they hadn't really thought about it, right? So I think getting even the Medicaid providers on board so they can think about, a lot is gonna be telemedicine, and it's gonna be a lot of, electronic medical records are crucially important to get kind of rolling along. There's gonna be a lot of full-time equivalents or employees that you've got to bring on. There's a lot of training that you've got to bring on. So all this stuff has to be discussed beforehand. And if you don't do that, you will have success, but it won't be near the success that we could have through these waivers.
My name's Dominic. I'm here from Boston College, and I have a question for Maggie specifically. So you have 2 nurse practitioner students here, and I'm wondering, as clinicians, how can we get our practice settings to begin adopting these programs and wanting to work with this population of people re-entering the community?
That's a great question. I think it's going to take a little bit of time. I think we are very fortunate. Our RISE team has grown over the last several years, and it's currently grant funded. And if there isn't that mechanism there right now, then I think it'll be difficult until this waiver is in place. I think every health center should be thinking about reentry services. Even if they're not able to go into the jails and do the pre-release work, then they absolutely should be thinking of who is our, community health centers, who is our population? Who are we working with? Is it neighborhood-based? Is it population-based? Who are they as a population, and how much experience are they having with the criminal legal system? And so what are the services that they need? Let's ask them. What can we provide in the outpatient setting, even if we're not necessarily able to go inside yet? And so I think that's part of whole person care. I think that, that is it's hard to think about new things to take on, but I think that's a pretty critical one. And when you look at a population-based community health center sort of approach, I think it fits really naturally in there.
I just add to that too. I believe that every organization that deals with reentry and people coming home that are homeless should know how to house formerly incarcerated people. It is not just I found an apartment, I want to fill out an application. There's a process that we created, hands-on defense process, and it has been 97% successful in housing individuals with barriers. We're going to be training other organizations in the state on how to use the hands-on defense process. It is crucial to being successful in getting formerly incarcerated people in housing. Not every landlord, not every management company wants to house somebody who is coming out of incarceration. Unfortunately, that stigma is still there. And so we've become experts in changing that narrative and teaching people how to advocate for themselves when we are not. And so we want, it's so huge that we want other organizations to do the work that we're doing.
Well, I want to thank you all so much for joining us in this first panel, and particularly for all of my esteemed panelists. Thank you so much for joining us. This was wonderful. I really appreciate it.